Lately, the phrase reintegrative therapy has been coming up regularly in conversations with my Catholic clients and friends. This therapy has also been promoted in recent interviews by prominent Catholic influencers, increasing its visibility in our circles. Today, I want to walk us through what reintegrative therapy is and examine a few of the key claims of this form of therapy to explain why I do not use it in my clinical practice or recommend it. I'm a licensed Catholic clinical psychologist working in Colorado, and I've been researching sexual and gender identity development specifically for people of faith for over a decade. I earned my undergrad degree at Ave Maria University and a graduate degree at Regent University. So, what is reintegrative therapy? Reintegrative therapy is a new therapeutic approach that, according to its developers, uses established evidence-based interventions, the same interventions used by other clinics throughout the world to treat trauma and addiction. As these dynamics are resolved, the client's sexuality can sometimes change on its own. Joseph Nicolosi Jr. is the founder of the Reintegrative Therapy Association, which has been promoting this approach since it became a 501c3 in 2017. The claim of reintegrative therapists is that they're offering an approach that is entirely separate from the controversial approach of conversion therapy. They define conversion therapy as any attempts to increase heterosexual attraction and decrease unwanted homosexuality with the help of, as they say, a usually unlicensed therapist. This definition of conversion therapy would include the approach known as reparative therapy, which actually gained prominence through the work of Joseph Nicolosi Jr.'s father, Joseph Nicolosi Sr. Joseph Nicolosi Sr.'s website states that, quote, he assisted over 1,000 clients in their goal to reduce same-sex attractions and explore their heterosexual potential. As a licensed clinical psychologist, he believed that our bodies tell us who we are, and that our bodies have made us for heterosexuality. Nicolosi Jr. and others who use reintegrative therapy emphatically state that it's distinct from conversion and reparative therapy in several ways, including attraction fluidity is a byproduct rather than the goal of therapy. At this point in my career, I can absolutely appreciate why Nicolosi Jr. would want to distance himself from the conversion therapy approach of his father. Many research studies document the harms of conversion therapy, and I've sat with many clients who share the ways conversion therapy metastasized shame and fear around their attractions that drove them into sexual acting out, isolation, and a lot of pain and self-guilt. Parents also come to my office and share about how conversion therapists told them that their child's sexual attraction was their fault, even though there's no research evidence to support this therapy. And for many people who went to conversion therapy, who talk about even positive or neutral aspects of their approach, they said that could have happened in any form of therapy. So by the time Catholic families come to see me, they're eager to meet with a Catholic therapist who won't overpromise and underdeliver a therapeutic cure for homosexuality. They've already spent significant time and money on conversion therapy through individual sessions, family sessions, groups, and retreats, and have found it wanting. Many of these individuals still want to maintain their Catholic faith and live in value congruent ways, but find this super difficult in the aftermath of an approach that made heterosexual attraction synonymous with psychological healing and spiritual wholeness. The impacts of conversion therapy and the harm there I've seen time and time again, especially in people's doubts in God's love for them in the midst of enduring attraction to the same sex. In fact, many people I meet with feel no choice but to walk away from their faith altogether. So I was really curious when Nicolosi Jr. shared that he's really different from his father, Nicolosi Sr., in his ideas on homosexuality. So I wanted to understand the degree to which reintegrative therapy's approach would provide something altogether different from Nicolosi Sr.'s approach after I'd witnessed the negative consequences of conversion therapy for over a decade. We want to start with engaging with the claims of reintegrative therapy. Several questions arise as I've tried to learn more about the reintegrative therapy approach. A first question is this: to what extent is the theory behind reintegrative therapy similar or different to the theory behind conversion or reparative therapy? This matters because theory has everything to do with what makes one approach in therapy different from another approach. It has everything to do with the interventions we choose to adopt in therapy and has a great deal to do with the outcomes we'd expect at the end of treatment. For reintegrative therapy to be truly distinct from conversion therapy, I would expect its theory of development of same-sex attraction to be radically different from that of the conversion therapist. This goes for any established treatment. If a person was offering an alternative to cognitive behavioral therapy, CBT, we would expect the theory behind the approach to differ in meaningful ways from a CBT approach. So when I look into the reintegrative therapy approach and listen to the video content put out by reintegrative therapists, especially the founder of the Reintegrative Therapy Association, I find the following theories of etiology, or the causes of same-sex attraction, as central to the reintegrative therapist's understanding of homosexuality, with a particular focus on male same-sex sexuality. So for the reintegrative therapist, same-sex attraction emerges because of at least one of the following experiences: early childhood attachment wounds, including having a distant father or a smothering or invasive mother, which reintegrative therapists would say leads to the developmental disruption in a young person's identity as a boy or a girl and their experience of the opposite sex. The theory follows that these attachment wounds will later manifest in sexualization of a person of the same sex and aversion to people of the opposite sex. Another possible causal path reintegrative therapists point to would be traumatic, unwanted sexual experiences or sexual abuse. Another would be traumatic early exposure to pornography, and yet another would be traumatic peer rejection. As far as I can tell, the theory behind reintegrative therapy is that of trauma of various kinds is going to cause same-sex sexuality to develop. So for the conversion therapist Nicolosi Sr., homosexuality is an adaptation to trauma. It's rooted in a same-sex attraction problem, an attachment to a person's masculine nature. I see no distinction between the theory of homosexuality between a conversion therapist and a reintegrative therapist, which cautions me against accepting the claim that they're different in approach. So if the theory behind these approaches is almost identical, you may be wondering, what is different between these approaches? For starters, reintegrative therapists say that their approach is different in that the goal is healing of trauma, not attraction change per se. We'll circle back to this point later more fully when we look at what reintegrative therapists are measuring as outcomes of successful therapy. Yet another reported difference is that whereas conversion therapists used aversion techniques, which are any efforts to lead somebody to associate disgust, pain, or displeasure with a behavior, a thought, or an emotion, reintegrative therapists report that their approach avoids these aversive techniques. I am grateful to hear that reintegrative therapy avoids aversion techniques, which have not been effective long-term for behavioral changes and have often taken forms that are outright harmful and deeply concerning. I've met with many clients who sought out conversion therapy that incorporated these aversion techniques, things like mocking their own voice inflection, their mannerisms, or their interests, in an effort to somehow reduce gender nonconformity, as if that would somehow increase connectedness to masculinity or femininity. It's difficult to fully appreciate the harm of these interventions on a person's sense of self and mental health until you sit across from somebody who's endured them. It is important to note that aversion approaches are not synonymous with conversion therapy, and plenty of conversion therapists sometimes also report that they don't use aversion techniques. I've also met with countless clients who sought conversion therapy and never experienced some of these aversion techniques, but were actually offered trauma-related interventions of various kinds. This renders the distinction made by reintegrative therapists actually less meaningful than we might originally think. The Reintegrative Therapy Association site also indicates that the approach is simply using trauma-based interventions, again, trying to distinguish itself from conversion therapy. And when I looked at the published paper on this approach, it appears that at least some of the interventions are evidence-based trauma interventions, such as using EMDR and self-compassion in therapy. So this raises the question, why do you need an altogether different trademarked approach? Why not simply be a trauma therapist offering evidence-based trauma therapy to treat trauma symptoms when those are present? If the goal is trauma treatment, not change of attractions and orientation, I struggle to understand the need for a new trademarked approach that measures change of attractions rather than trauma symptoms at the end of therapy. And as a Catholic, I'm aware of no official magisterial document that claims trauma is the cause of same-sex sexuality. I also see no indicator in church teaching that the Catholic who experiences same-sex sexuality ought to seek trauma therapy and expect change of attractions or orientation in order to be faithful to Christ. In fact, the available documents related to same-sex sexuality indicate, in quote, "There is currently no scientific consensus on the cause of the homosexual inclination," end quote, and make it clear that there's also no consensus on the helpfulness of therapy to change attractions. This is in keeping with the current science, where there continues to be no consensus on the theories of causation, contrary to what reintegrative and conversion therapists alike confidently claim. So are the theories of the development of homosexuality different enough between conversion and reintegrative therapists to indicate them as distinct therapies? It's clear that Joseph Nicolosi Sr., the founder of reparative therapy, believed the very same thing about same-sex sexuality that his son, the developer of reintegrative therapy, also believes. Both claim that same-sex sexuality is caused by attachment trauma and other forms of trauma that disrupt developmental processes, despite no scientific consensus or scientific basis for this theory. This calls into question any meaningful distinction between reintegrative therapy and conversion therapy, as their theories are really the same. Whatever differences exist between these two forms of treatment are much less relevant than the driving theories that anchor their shared approach. Is it accurate to assume that same-sex sexuality is a symptom of trauma? One mistake that the reintegrative therapist makes, that the conversion therapist also makes, is that they both assume trauma symptoms are present with every client who experiences same-sex desire, in line with their theory of homosexuality, rather than assessing for and documenting trauma symptoms that ought to be addressed with trauma interventions. To assume that same-sex sexual desire is itself a trauma symptom is just that, an assumption. It may seem logical to some of us, but that doesn't mean it's an accurate assumption. As a trauma therapist who often works with survivors of complex trauma, I would caution any therapist against assuming trauma symptoms when they aren't present and being reported by the client. Every therapist runs the risk of making assumptions, especially when we work in a particular area of specialty. Our biases can lead us to see trauma where it isn't, just as a therapist who often works with people with bipolar illness or autism might be prone to overdiagnosing it. Too often I've heard from individuals who have sought reintegrative therapy and conversion therapy and have been told that they have trauma histories, even when they consistently tell the therapist that they don't. The exhaustion of being on a wild goose chase to find the trauma is hard to appreciate until you've lived it. I've also sat with people who were put through EMDR protocols by reintegrative therapists without being told that EMDR is a trauma treatment and without themselves having a history of trauma. These individuals only discovered the fact that they were being treated for a trauma disorder they were never assessed for when I told them that EMDR is actually a trauma treatment. This begs the question of informed consent and client autonomy versus a therapist's assumptions driving treatment. From a trauma-informed perspective, pushing, even subtly, a theory on a client who doesn't believe they have a trauma history is at best disrespectful and at worst coercive. Expecting a client to address trauma without the client's willingness or awareness is not trauma-informed, but actually runs the risk of enacting trauma dynamics, power and coercion in therapy. Surely, as a trauma therapist, I've met with people who report trauma symptoms, things like flashbacks, intrusive thoughts, emotional and thought disruptions that came from trauma, but really struggle to name or talk about their experiences as traumatic. And of course, I would love to help them come to a place of freedom in acknowledging and addressing these symptoms. But I recognize the damage in beginning to treat their trauma without their consent or understanding of this reality in their life. This becomes especially problematic if, rather than measuring or observing objective trauma symptoms at the start and end of therapy, a therapist were to assume trauma is present based on their own personal theory about how same-sex sexuality comes to be. And even when a client who experiences same-sex sexuality has a history of trauma, there is no research base to support the claim that trauma causes their same-sex desires, or that addressing their trauma will make their attraction change. The next question worth asking as we explore reintegrative therapy is this: is there significant research evidence to demonstrate that reintegrative therapy does what it says it does? Anytime I'm looking into a new treatment approach to consider incorporating in my practice, I look at the research base. I wouldn't say reviewing research is the highlight of being a psychologist, but it's a necessary part of ensuring the therapies that I offer are grounded in something beyond my own interest in them or a personal or cultural perception of their efficacy. So when I look at the Reintegrative Therapy website's research, it states that it has large-scale, longitudinal evidence that reintegrative therapy, and I quote, is associated with statistically significant decreases in same-sex attractions, increases in heterosexual attractions, changes in sexual identity toward a heterosexual identity, and increases in psychological well-being, including decreases in anxiety, depression, and suicidality. To any reader, this statement likely sounds astounding, promising, and intriguing. Words like large scale and longitudinal evidence pique our attention, even if we aren't familiar with research jargon. Many people seeking out this approach are desperate to find a way to get rid of their same-sex attraction and will do whatever it takes if told there's strong evidence their attractions can change. So let's dig into these terms. Large scale, as defined by the social sciences, refers to extensive research programs and networks that bring together researchers from diverse backgrounds to address common global issues requiring significant human and financial resources for interdisciplinary and international collaboration. So we would typically expect a large-scale study to at least have hundreds of participants. Longitudinal evidence means that the participants in a study are followed over a sustained period of time. This is meant to help us demonstrate sustained shifts rather than natural shifts that return to an original baseline or would have recurred regardless of intervention. Having a longitudinal study where a majority of the participants stay in the study is actually what gives credence to the conclusions we draw about the effects of a therapeutic intervention. The single study, Palin-Sutton 2021, that's cited to support reintegrative therapy began with 75 participants, which is a non-negligible number, but it's nowhere near what we would need to qualify a study large scale. Less clear from the summary statement on the website, only 22 participants remained in the study for the 2 years they were being followed. This is an incredibly low retention rate of 29%, which severely limits what can be said conclusively with the available data. If you heard a therapist claim that I read a study that followed 22 people for 2 years of therapy, and because of this, we have large-scale, longitudinal evidence that this new therapy is effective, you would likely have a different reaction to the claim than if you were told, I read a study that followed 75 people for 2 years and have large-scale, longitudinal evidence that this therapy is effective. And even if all 75 people stayed in the Palin-Sutton study for the entire 2 years, that would only be evidence from a single study of a totally new therapy. It's important to be honest about what we can and can't say from a single study. And we have to be all the more modest when the majority of the participants of a study drop out before the study's completed. And we actually have no way of knowing the eventual outcome of 71% of the original sample's trauma symptoms, mood symptoms, or their sexual attractions. So until more research is done that would indicate that reintegrative therapy does better or is equally effective as trauma therapies in treating trauma symptoms and show that specific trauma symptoms like nightmares, flashbacks are significantly improved, and demonstrates this through repeated studies with a similar outcome, I would encourage clinicians to address trauma symptoms when present in clients with established trauma protocols that are well researched. Large-scale, longitudinal evidence of reintegrative therapist claims may come, but it doesn't exist from the current research available. A final critical question to answer about reintegrative therapy is this: is it true that reintegrative therapists are not attempting to increase heterosexual attraction and decrease unwanted homosexuality? The repeated phrase of reintegrative therapists is, in quote, trauma treatment is the goal. sexuality change is often the byproduct. As a therapist who works with many Christian clients who are navigating sexual orientation questions, some of whom have trauma symptoms, I measure outcomes in therapy using evidence-based measures, such as assessments to treat depression, anxiety, and PTSD symptoms when they are present. These measures will tell me whether a person's symptoms have improved over the course of therapy and the primary goal of therapy is met. What I measure is perhaps just as important as what I don't measure. The symptoms or experiences or behaviors I don't measure aren't ignored simply because they don't matter to my client, but I don't measure them because they're not the symptoms that I'm attempting to primarily treat, and they aren't my client's primary goal. What we measure shows what we are prioritizing. So let's say a client of mine has a diagnosable eating disorder and a range of other behaviors that she would like to be different, including compulsive spending. In therapy, I'm working with her using evidence-based interventions to treat her eating disorder based on my theory of how eating disorders come to be. At the end of therapy, I will be interested in her measuring her eating disorder behaviors, the intensity of eating disorder thoughts, and her feelings about food and her body through assessment and conversation. This is because her eating disorder is the primary diagnosis she's here to treat. And even while I may hear her share at the end of therapy that she has or hasn't gotten a handle on excessive spending, I would not be invested in measuring compulsive spending unless changing that symptom is a goal of therapy. Further, I would not be invested in writing up research articles to demonstrate that compulsive spending was addressed by my treatment of her eating disorder. Or at the very least, I might report changes of eating disorder symptoms and compulsive spending in a research article to show treatment efficacy in accomplishing her and my reported primary goal. If I were to focus my report on compulsive spending behaviors, thoughts, and feelings, it would indicate that what I care about is reducing compulsive spending through eating disorder treatment, not treating the eating disorder symptoms themselves. This analogy is really helpful in illustrating why I doubt the assertion that reintegrative therapists' goal is trauma treatment as opposed to decreasing same-sex attraction and increasing opposite-sex attraction. It seems fair to assume that you measure and document what you care about most, and what reintegrative therapists are measuring and documenting in their research and on their website are shifts in experience of same-sex attraction and opposite-sex attraction, thoughts, feelings, and behaviors, and general mood symptoms. The reported outcomes do not report on specific trauma symptoms in any meaningful way. So let's look more closely at what Pela and Sutton 2021 measures at the end of therapy with clients. The measured outcomes of therapy that are reported in their study include an overall assessment measure that looks at progress in therapy and functioning in the areas of depression, anxiety, and suicidality, and self-reported thoughts, feelings, behaviors, and identity labels tied to sexual attraction. In fact, there is no inclusion of measures that would be typically used to evaluate if trauma symptoms are significantly reduced or present at the start of therapy for that matter. So if the goal is trauma symptom reduction with secondary potential for changes in attraction, why not measure and report on the trauma symptoms themselves? How can you gauge if reintegrative therapy treats trauma, the reported goal of the therapy, without reporting about the nature of specific trauma symptoms at the start and at the end of therapy to demonstrate successful trauma therapy? The burden remains for reintegrative therapists to show that reintegrative therapy uniquely and effectively treats trauma symptoms it claims to prioritize. To do so, researchers would first need to demonstrate that the people they are treating have trauma-related disorders, not simply same-sex attraction, to warrant trauma treatment. They would also need to incorporate measures that assess specific trauma symptoms and demonstrate significant decreases in these symptoms that are sustained over time. Until then, I'm left to conclude that reintegrative therapists are more invested in showing perceived changes in sexual attraction than reducing trauma symptoms. This calls into question the repeated claim that attraction changes are byproducts, not the goal. It bears repeating that nowhere in official church documents, including available guidelines for ministry to this community, are Catholic individuals encouraged to pursue or recommend therapeutic healing of trauma and or attraction, orientation, and identity changes in the midst of enduring same-sex attraction. The Catholic Church recognizes the lack of consensus in psychological science about causes of same-sex sexuality and also indicates there is no consensus about the value of therapy in regard to change. I only wish that Catholic reintegrative therapists would be as cautious and tentative as our church in this regard. And if they won't be, it's really important that we be honest in our communities as best we can about what God is and isn't asking those among us who experience same-sex sexuality. Thank you so much for watching this video. I hope you enjoyed it and found the content helpful. My name's Dr. Julia, and I'm a licensed clinical psychologist working in Colorado. I regularly consult with Catholic churches and dioceses, seeking to better understand the sexuality conversation. If you found this video helpful and you want to follow more content that I'm offering, consider joining this community and joining the Patreon. To follow more of my research and clinical work, you can always follow my website, which will be listed below. If you have additional ideas or comments on the videos, consider putting them in the comment section below.